We have to add several data to try to diagnose things. Thank you for the presenters, the organizers. Thank you, Dr. Tarek Al-Yasti and Imad Nagib. Thank you very much. Shukran. Imaging, the objectives are to try to give some specificity to the lesions, highlighting location. We are going to discuss very briefly childicitis, vertebral pate spondylodicitis, arthritis of the interapophygeal joint, the epidural and subdural abscesses, spinal roots, radiculitis, spinal cord granuloma, myelitis and abscess, and myelitis. The discs of kids are very well vascularized, so the pathogens go straight to the discus, and the infection is the decitus in child. It's a very difficult clinical diagnosis, but the magnetic resonance is very straightforward. So the infection begins in the disc and can go or not go to the bone itself. The disc is very well vascularized. So the infection begins in the disc. The pathogens are most commonly, like for the adults, Staphylococcus aureus, but now between 6-month and 4-year-olds, there is a Kingella kinga kind of bacilli that becomes the most common agent in this age group. In the adults, thanks to the very peculiar circulation of the bone, the infection begins in the metaphysis. So the infection begins in the bone, is an osteomyelitis, and then spread through the disc, and after that to the prevertebral and extradural spaces. But the infection begins in the bone, so it's an osteomyelitis. The most common agent is again Staphylococcus aureus, but Enterobacteria is still very common in adults and old people with immunosuppression. It becomes common also. Spondylodicitis, the starting point is the anterolateral vertebral body plate. So it's an infection that begins in the bone, and infection extension to the intervertebral disc. And then we have two options. Some pathogens has proteolytic enzymes, and we like the pyogenic spondylodicitis, and again Staphylo aureus and Enterobacteria. And some pathogens have not enzymes. So then we have tuberculosis. So the evolution of the infections are a little different. The pyogenic spondylodicitis, we can see the necrosis and the abscesses forming mostly in the disc and in the prevertebral and extradural spaces. Most commonly single level involvement, although we can have multiple level involvement, but most commonly single level involvement. The abscesses are mostly, not only, but mostly intradiscal, and the paravertebral masses are most frequently without necrosis. There may be abscedation, but it's not common to have necrosis. And the posterior vertebral involvement is very rare. It's very uncommon. The tuberculous spondylodicitis, by the other way, the necrosis is mostly inside the bone. It's most commonly inside the bone. And the diffusion of the infection is mostly through the prevertebral and the extradural spaces, not through the bone and the disc itself. So the discs are relatively protected against the infection. So it's possible to make with a certain, the differential diagnosis between the two conditions. Although we have always to try to have material, to put a needle and to get material. But not always it is positive. So many circumstances they have to begin to treat without the agent completely discovered. So tuberculosis is more frequently multi-level involvement. The intraosseous necrotic cavities, paravertebral masses with cavitated and necrotic centers, and posterior involvement is more common than with pyogenic spondylolisthesis. Epidural abscess, in the past we used to think that it could be epidural abscess by itself without a cause. But today we know after MRI that there is only a cause, that always we can find the cause behind the lesion. It's a kind of complication of catheter for analgesia, and we can see here the diffusion restriction of the abscess helping to make the diagnosis. So we know the cause, and the primary epidural abscess with no other infected elements are extremely rare in the area of MRI. So almost always we find the infection in the disc itself, in the bone, or in the articulations, interopophyseal articulations posteriorly. Subarachnoid racemose cysticercosis. This is that the developed countries are free of this, and the Islamic countries are also free of this because you don't eat pork. But we have it in South America, it's prevalent. So sometimes we find this kind of infections in the subarachnoid space. You can see the cysts that reach the CSF through the choroid plexus, and then they go to the CSF, and for gravity, they stand in the bottom of the canal. It's not frequent, but it's not rare, unfortunately, in spite of all the health measures that we try to improve, but it's still prevalent. The nerve roots are most commonly affected. The most common agent for the compromise of roots is cytomegalovirus. So when we see a strong enhancement of roots, the first thing we think is cytomegalovirus, but in no way it's specific. So we have all these cases of enhancement of roots. It's a big differential, and we have always to have the support of laboratory data. So it's more common cytomegalovirus, but there's a lot of causes of root enhancement. The Guillain-Barré syndrome is a kind of we saw a lot of this syndrome with the COVID infections. So it was part of the spectrum of neurological involvement in COVID. And the involvement of the roots is mainly of the anterior roots. So there is some specificity when we have the Guillain-Barré, although the diagnosis is very easily clinically for the paraparesis, ascending paraparesis, and the finding of the CSF with dissociation of proteins and cells. The findings in MRI are very similar. Cysticercosis, again, we naturally didn't make this diagnosis of cysticercosis on imaging. I particularly thought it was an ependymoma that is much more common with this kind of aspect, but is the platyhelminth tinea solid. So thanks to the Islamism, you are free of this. But in South America, in Asia, and even in the United States, because of migration factors, we can still find this kind of infections. This is the finding during the surgery, and thanks to the surgeon, it was completely removed, and the patient is almost without any deficit after the surgery. Schistosomiasis is something that you have here. You have the snails, and you have the schistosoma here. And so when we find some kind of swelling and some kind of nodular enhancement or serpiginous enhancement in the conus medullaris, we have to think in my country that is an endemic zone of schistosomiasis in this hypothesis. And the diagnosis is confirmed by an assay, an immunoassay test, or by rectal biopsy. So schistosoma mansoni and all its cycle that we are not discussed here. And this is the finding of the schistosoma and the formation of granuloma. So besides tuberculosis, we have this kind of lesions that are not common, but by the other way are not rare in my country. Now we are going to try to discuss the myelitis, where magnetic resonance is very unspecific. So we have almost always to rely on clinical data and on laboratory data. But anyway, I will try to give some clues in order to think or to narrow the differential diagnosis. So infections may cause transverse myelitis. We have the demyelinating diseases that Dr. Rovira is going to show for us, multiple sclerosis, neuromyelitic optic spectra, myelin oligodendrocyte glycoprotein, the myelinating disease of the conus. We have the para-infectious. Sometimes we have an infection, but the damage to the spinal cord is not the infection itself, but is para-infections. So it's not very simple. We have the systemic autoimmune diseases like systemic lupus erythematosus that these days are becoming very rare, the involvement of the cord, but we still have it. We have paraneoplastic myelitis, and we have some mimics like radiation, metabolic situations like deficit of vitamins, tumors, and fistulas. So the differential diagnosis is broad. And sometimes we call it idiopathic, but this idiopathic is our ignorance. So in the future, we will not have this kind of idiopathic thing. We have learned that multiple sclerosis, it's a short longitudinal lesion that is less than 2 vertebral bodies length, and it involves less than half of the spinal cord diameter. We have the spectra of neuromyelitis optica, where it's a long segment involvement of the spinal cord, more than 3 vertebral segments. And we have this kind of cavitation of necrosis that may be found in the complete, when the cases are where easily, with all the complete findings. And this is the finding of the most commonly the myelin oligodendrocyte glycoprotein. Finding is this. They are not absolutely pathognomonic or nothing like that, but it's most commonly present this way. The viral myelitis, we have a lot of them, most commonly the herpes virus and varicella zoster virus, but we have the retrovirus, and in my country, arbovirus, chikungunya, Zika, and dengue are also causes of myelitis. Other influenza and rabies. This is one short segment in the left side, in the cervical spine, and a long segment involvement of the spinal cord. The compromise is mainly in the central part of the spine. But anyway, it could be demyelination. So we have to always see the exam of the spinal cord, the brain examination, and the laboratory and clinical data. It's impossible to work without all these informations. The findings are. So this is a short segment. It could be a multiple sclerosis lesion in the proper clinical setting. But the PCR was positive for cytomegalovirus, a central lesion, short segment. We have longitudinal extensive transverse myelitis. So I'm going to show the several causes. This is syphilis. This is tuberculosis, all long. This is neuromyelitic optica. This is acute demyelinating encephalomyelitis. This is herpes virus, and this is human lymphotropic immunodeficiency virus and human trophic lymphovirus. The enhancement patterns can sometimes help. Sarcoidosis has a very typical kind of enhancement that comes from the pia through the spinal cord. But you see, the chikungunya virus enhancement is very unspecific. The abscess is the same we find in the brain. And again, we have schistosomiasis. So this kind of serpiginous enhancement in the conus medullaris in an endemic zone suggests the pattern of the infection. This is one situation that we can be pretty sure that the virus is affecting the spinal cord. So when we have herpes zoster myelitis with a clinical evidence, here we have a radiculitis, the fifth cervical nerve is involved with enhancement. We have enhancement around the vertebral body, and we have the lesion in the gray matter of the spine. So this is very typical. I may say that a virus is there because all the findings we are considering. The involvement of the posterior part of the spinal cord is typical of HIV myelitis, as we all know, and Lewis, syphilitic myelitis. Again, the diagnosis is made by the VDRL. So the routine today is routine for every patient in the hospital to have a VDRL. But the lesion could be virus, could be demyelinating. So again, it's very unspecific. But the involvement of the posterior part of the spine, so the lesion is posterior, suggests that syphilis is one of the causes. The mimetizers are vitamin B12 deficiency, HIV myelopathy, and copper deficiency. So we have always to put these possibilities in the differential diagnosis. The involvement of the central portion of the spinal cord. This is a patient of 50 years old with COVID-19. After 2 weeks, she presented with dysesthesia, weakness in the legs, and proprioceptive deficit, IgM and IgG positive. The lesion is central, the involvement is central, so this was viral involvement by COVID-19, as far as we can consider, because we have the positivity of the COVID-19 in the CSF. And these are the findings in the lungs that we all know. Unfortunately, we are used to this. But see, again, this is a 16-year-old boy with fever for 20 days or tracheal, followed by a skin rash. 10 days later, he evolved 10 days later with lowered level of consciousness, spastic paraparesis, and motor dysfunction, followed by tetraparesis. So we have involvement of the spinal cord. of the central and lateral portions of the spinal cord. It could be a virus itself, but it was a patient with chikungunya positive virus, but the findings are typical of acute demyelinating encephalomyelitis. So always we have to be considering the lesions and clinical and laboratory data. Imitators of the central kind of lesions are ischemia, the most common lesion that affect the central portion of the spinal cord is ischemia, and sometimes, not very frequently these days, thanks God, is the involvement of the systemic lupus erythematosus associated with antiphospholipids antibodies, involvement of the spinal cord myelitis. This was in the Zika encephalomyelitis. So we had a pandemic, an epidemic of Zika virus in South America 2 years ago, and this kind of finding. The most typical involvement of the anterior part of the spinal cord are the enterovirus. So we can have some specificity. Although in the acute phase, the involvement is diffuse of the whole cord. With the evolution, it localizes in the anterior part of the virus. The take-home messages are MRI is very sensitive to detect and characterize spine and spinal cord infections, but MRI is very unspecific, and the final diagnosis rely on clinical and laboratory data. Some imaging findings may help to narrow the differential diagnosis and guide further investigations. Topography, longitudinal and transverse extension, and pattern of enhancement. I would like again to thank the Egyptians for the meeting. This is a long travel. Imad Naguib went to Brazil and he did the opposite travel. And this is my family. I brought my whole family to know Egypt. We spent the 2 last weeks here. We learned a lot, and I have to study a lot because it's a wonderful, wonderful experience. Thank you for the opportunity. Thank you very much. Shukran.